Alison Nohara, who's going to talk to us today about neurological disorders in pregnancy. She's really very good at what she does. She saves people from strokes. She takes out clots. I mean, it's just amazing. Yes. And here she is. Thank you very much.
Thank you guys for saying. I know it won't be as exciting as discussions of call and all that sort of stuff. Clearly, basically, I actually gave this talk a few years ago because we actually had a ICU full. We had no breast pumps because we had 4 patients that had just given birth that had strokes. They were different. I actually got to see my first amniotic embolus. I didn't ever think I was going to see one of those. We got to see one of those. We had press, we had dissection, and we had clot. So it was all of a sudden in our face all at one time. And of course, you don't get to see them that often, thankfully, because you take the happiest day of someone's life and make it not the happiest day of someone's life. So, let's see. Becky, I can use this?
Yes.
Okay. So what are the rates? My husband I had him look over this because I said he's my, help making sure that I spell everything correctly and all that sort of stuff. And he's a statistician. And he goes, what? I hate this when you do this type of stuff, Alison, when you give these ranges that are so broad. The problem is that when you look at any type of, and I actually pulled the NIH public access for this, when you start pulling data, the data is very sparse. And so what happens is your ranges go really all over the place. Generally speaking, about if you were to look at it, it's about 8 ischemic strokes to every 100,000 births. That's not insignificant. And the bleed rate is actually higher. And it turns out it depends on what type of bleed you're talking about. AVMs tend to rupture in the first trimester because of all of the changes in blood flow and blood dynamics for the woman who has the AVM. We all worry about aneurysm, for example. The likelihood of an aneurysm rupture is basically almost what it is in the natural population. So, and we still do C-sections, and then we'll talk about some of the risks of doing C-sections because it actually turns out that there are some risks of doing C-sections in these patients because it actually may predispose them to changes that are actually, can actually do exactly the opposite of what we think they're doing. It's not necessarily commonsensical that, oh, just because they have an aneurysm, we should be C-sectioning so they don't go through labor. All right, and so the interesting thing I saw is this number right here, is that if you do have an intracranial hemorrhage in your pregnancy, that is a huge percentage of pregnancy, which is, I thought, pretty interesting. So what are the associated risk factors? Why? I mean, these are normal complications of pregnancy, but these are what lead to an increased association with stroke. You guys have seen all of these things in your patients, I am sure. Anemia, because we all are all anemic, but postpartum hemorrhage, electrolyte, disorders, infection, and then, like I said, there's some special things around that C-section. We'll get to. So ischemic stroke, which is actually the more common type of stroke in the broad population. If you were to say take all strokes coming in the normal population, about 90% of them are ischemic. What you can see here is that in pregnancy, for some reason, well, not for some reason, we actually know why, because of the hemodynamic changes, there's a much larger percentage of patients that have hemorrhagic stroke than have ischemic disease. When you look at this, actually, the venous occlusive disease is probably the most common when you look at why a woman is having stroke. But there are some other things that happen. We'll run through some of the more common things that we see in the general population, which is that thromboembolic complication. And then one thing that happens is Sheehan syndrome actually happened to my sister's best friend and was completely undiagnosed. And she almost died. She had a serum sodium coming in at 118. She was told that the reason her breast milk wasn't coming in was because she wasn't drinking enough water. So she decided to go ahead and drink. In her headache, oh, well, that's just because you're a wimp, was what she was told. Your headache is going to be fine. And she's like, I have this horrible, horrible headache. She's a marathon runner. She knows pain. And no one was listening to her, and like I said, she came in, and if it wasn't for the fast thinking of a lot of people, she would have died. So it's something that hits me very personally from that standpoint. Other neurologic disorders, you guys see this quite frequently, and y'all heard of that. And then this one I want to touch on, just because actually most of all of you I see that the most frequently. And there's some interesting things about it because we talk about it as posterior reversible encephalopathy syndrome. It's not always in the posterior circulation. It's not always reversible, and it doesn't always come with encephalopathy. So it's kind of an interesting way they describe it. That we'll go through that. So this is, again, this is one of those things where if you look at the compilation of 21 studies, you're getting a huge variation. So is there good news? Well, the good news is that the prognosis in the pregnant woman is actually much, much better than in the general population. So if you think all my ischemic strokes that go upstairs, you have as bad incidence for pregnant women. Other people say it's not. I will tell you. Get through those couple of days, it's rest, that's better. And I can pick out some motivation, to be honest with you. You know who they are, they come together to go back to it. They want to push through it rather than therapy anymore, type sort of thing. So causes, hypercoagulable state is, as you know, is one of the things that we talk about. Eclampsia, hormonal alterations, comes into play when you talk about Sheehan syndrome, but it also comes into play when you talk about hypercoagulable states because that's part of it. And then we talk about stress forces. This is what people really focus on when they're talking about, justification or why we want to put everybody that has an AVM or an aneurysm through a C-section. But then what we have to understand is that there are physiologic changes that can increase just based on that type of invasion to the body that can also lead to problems. Timing, entities such as AVMs and aneurysm, they can occur at any time during pregnancy, but as I was saying, the peripartum or postpartum, and actually it's really focused in the first 2 weeks postpartum. AVMs are a unique entity, like I said. They tend to have an increased spike in that first trimester, and like I said, the reasoning is considered because of all of the hemodynamic changes that are occurring in the mother. So I thought running through some of these cases might be a little bit more fun than just listening to me banter on and on. So ischemic venous occlusive disease, I did go forward. Hypercoagulable states, we talked about protein C, protein S, and you can see that actually changes within the, because of the physiologic changes of pregnancy. Obviously, our sickle cell patients or people we know with these deficiencies are at a much higher risk. This makes up 2% of all ischemic stroke in pregnancy, which is much higher than the general population. We don't see much venous occlusive disease in the general population. We see it kind of 0.2%. So this is a tenfold increase in your patient population, and is 12 per 100,000 births. Okay. Oh my God. Go backwards. There we go. Okay. And like I said, the highest incidence, again, this kind of follows that thing for the last trimester when they're the most not moving, because now they're not moving and they've got all that weight on their legs. So you understand that these clots can form because of just not moving and stuff like that, but also because of all of these things that are played a role in that. And then, like I said, up to the 2 weeks post-delivery. So we do see it after they deliver as well. So a little different from eclampsia in that regard. The presentation is usually indolent but very progressive. So what happens is that you see neurologic changes, but they're not like what you expect to see a stroke, where one arm isn't moving or one leg isn't moving. It's like they're not really moving one side, but then now they're not moving the other side either. Because when you talk about the veins, it's like the dam building up, right? This isn't, the arteries are moving okay, so the brain is getting filled. But what's happening is that there's no outflow. And as that outflow decreases in its ability to go out, you get what's called venous hypertension. And what happens is you get a boggy encephalopathic brain until it really stops. And so what happens is it progresses, it marches, it's slow, but then all of a sudden it's like everything. And all of a sudden, you walk in and the patient's not doing anything. And you're like, what's going on? We can actually see headache associated with hemorrhage. And in spite of hemorrhage, the treatment for this is actually anticoagulation. We can see seizure because of that bog, like I said, that encephalopathic type of thing. And obviously papilledema because of the swelling. So this is, here's a patient that's kind of typical of you guys. We like these brains because that looks great to me. I usually see a lot more atrophy. You guys have young people coming in because they're in the prime of their life. And we actually see a little hint right here where there's a little hyperdensity along the distal portion of the sagittal sinus. Otherwise, that's a pretty normal head CT. When we do the angiogram, however, and this is not the typical angiogram, this is way out into venous phase, we don't see the sagittal sinus, which this is AP, this is lateral, and so you should be, sorry, they're very close together, so I have my big cloggy thumbs. The sagittal sinus should be running like this on the lateral, should be running right down the midline here. We don't see it, and you see a little bit of the transverse sinus maybe right here, but you definitely don't see it on the side that it's being injected on. You don't see it to here. So this is, and you can see all of this is just hanging out in capillary phase, and this should be gone. So that's what I mean by venous hypertension. The flow just sits there. You're getting it in, but it's not going anywhere, so then at some point you don't get any more in. So you're not getting the oxygen. What? Generally not. It's generally just anticoagulation and a lot of crossing of every, you start doing your legs and your toes and hoping, because a lot of times you just hope that these open. There are ways of going in there. Generally speaking, if you have something like this is a hugely bad prognosis because if it's this extensive. If there's just one out, you can generally buy them through. I've seen women with a vein of Lebet just off to the side, and they hemorrhaged from it, and then you can give them, you can heparinize them through that and get them, and their headache goes, and you just keep watching, making sure that the hemorrhage doesn't increase, and you just hope that that will ultimately be reanalyzed, or they'll find the other side to use more effectively. So, but it's a lot, and we see this also for the GYNs in the room. We also see this with contraception. Patients that are at risk, and you didn't know they were at risk, and they go on oral contraception, they can actually increase their risk, and I've seen that too. And again, it's tough because these are young women that come in, and they have usually that patient population is usually a headache is their primary symptom. They come in, they're like, I have this horrible headache, and they get a CT scan, and it shows a hemorrhage. But in the OB patient, it's more of the encephalopathy because you guys think everybody has headaches and stuff like that, complains of stuff after they give birth, right? So, yeah. So looking at ischemic stroke with thromboembolic complications, this is the typical thing that we see on the arterial side. There are, again, hypercoagulable states can give clots in the arteries, the venous system. We can see pericarditis cardiomyopathy, which often starts happening. Heart go up. We can see vasculitis. Autoimmune in this. This can create intracranial stent. Example of that. Dissection is the one that for whatever reason, I feel like my I have actually treated about 6 dissection in stroke. And it's usually because dissections occur at one time, and it usually takes a couple of weeks for it to, for the actual ischemia and the clot in the vessel to cause a actual flow occlusion. It's usually about a couple of weeks down the road that they actually, so they're actually at home taking care of their baby, and all of a sudden they have an ischemic stroke. And so again, it's pretty, and then there are rare forms. We talked about the amniotic fluid embolus. I actually saw one, so I guess I can stop now. No, they talked about choriocarcinoma and their too. I haven't seen that. Well, you have your migraners, right? And the migraners can actually get worse during pregnancy because of the hormonal. So usually something, the headache for a bleed in the head is very, very different. And anybody that's had a migraine will tell you it's different. It's very different.
So that's usually what I ask.
Yeah, is it different from your usual?
Like, how would I otherwise know? Okay.
And photophobia can be associated with it. So if they really are like they don't want to, they keep their eyes closed or they're wearing sunglasses, something unusual like that, then that should kind of spark some. And then, it's not the worst thing in the world to do a head CT or an MR of the brain. If you really think that something's just a little off, you don't get a good feeling about something. I think sometimes our guts are more important than our brains sometime in these things. Is that if you really don't feel like something's not fitting together right, like you have a migrainer who on the last pregnancy we did okay with it and now is suddenly out of control, you may want to think about it, because migraineurs have an increased risk for hypercoax, and for vasculitis because they are very vasoreactive, those patients, they tend to be. We give angios and they all get their migraines, so we know that they have a more reactive bed. All right, so presentation, this is more what you expect. This is the focal neurologic deficit, the not moving of one side, the neglect, the not speaking, those sorts of things, and it depends on the arterial distribution. They can have headache, they can have seizure, they can have neck pain when it comes to dissection. So they're claiming that they have pain, and that there may be something going on because, and I'll show you an example of dissection that we see. So here's the cardioembolic stroke. Here's a CT. Don't mind this is the normal variant of a megacisterna magna, but here's the CTA where we can see the arteries, the ACAs on both sides, and the MCA coming over here is normal. And you can see the cutoff right there. Sorry, this is not projecting as well just because of the lights. Here's Don't go sleep on me. No. Hopefully I'll keep you awake. So here's the looking AP. So the eyeball sitting right here. This is that internal carotid artery going up to the ACA. You can see all those nice ACA branches doing. Oops. I swear I'm not doing that. But and then you can see the cutoff of the MCA. What's really telling is right here, where you really see no MCA branches. You can see the PCOM right here in the PCA filling. You can see the ACA. It's a nice anatomy because, again, young women, they have beautiful vessels. It makes it nice for us. Unfortunately, it also increases that anxiety because you really need to reverse this. So this is, we talked about me pulling out a class. I said I would show you. This is our device. You can see this is my nice bloody hand. There's that stent retriever that we use. This is that booger that was in that MCA that was causing the occlusion. It's pretty humbling to me that, this is a 4 millimeter in diameter by 15 millimeter in length. So that clot is about 2 millimeters in width by about 4 millimeters in length, and that was making the difference between this woman living and dying. And like I said, I'm humbled every day I work in this because you realize how little it takes to make badness. Let's go through a vasculitis picture. This was a patient that, they didn't know what was going on. She was kind of having some vague symptoms. She was kind of having hits on both, she had hits on both sides, but she had a lot more hits on the right side of her brain. This is an MR, and we couldn't figure out what was going on. She'd have like a little episode where she was weak, and then she would kind of get better. She was actually, she was a little challenged mentally, and, she lost this pregnancy. I will never forget this woman because she actually had a baby that they kept putting back in the morgue, and then they brought it for her for grieving. You guys do this? Mm-hmm. And so I thought, they told me that the fetus had demised, and I go into the room to consent her for the angiogram and what I had to do, and there's the baby. And she introduces me to the baby, and I'm like, and I'm looking, and the baby's not moving. I'm like, what is it? I was like, she didn't look so hot, so I was like, oh, maybe that's just the way. And I'm like, I walk out of there, and I'll never forget, I'm like, the nurse was like, looked at me, she goes, are you talking about the baby? I'm like, is that when my face is all contorted? She was like, yeah. And I go, she goes, it's dead. And I go, oh. I was like, but she kept cuddling it. It was just interesting. I thought it was creepy, but she like I said, she had some mental challenges, and that's probably because she has some interesting disease. Oops. I did not do that. So here we are in AP again. Here's that ICA. You can see our devices coming up. She has this very high-grade stenosis right here at the end of the ICA terminus, so going into the MCA. And this is the reason that she was having a low flow state, so she kept having stuttering symptoms of this. She actually, this is a vasculitis. This is a 24-year-old woman. This is not acquired atherosclerotic disease. I mean, the rest of these vessels look very good. I mean, there's no athero anywhere else. So if you have, this was in your 80-year-old, you might consider this to be an acquired atherosclerotic disease. In a 24-year-old postpartum woman who I think probably is having vasculitis everywhere, and that's why she was losing her pregnancies, but we've had to look at her more closely. But this is that, we ended up opening it up, and you can see the restoration of flow in the MCA distribution. And that's, so she was in a low flow state. And we don't like to stent these because these are, again, a reversible, it's a vasculitis, so it's an inflammatory process. So when you ask if you put somebody on steroids, this is the person you put on steroids because you want their immune system to stop it. And so we put her on pulse steroids and gave her some interferon as well to make sure that this went away. And I think she did better overall because my guess is that she was having it probably everywhere.
What serum markers of her vasculitis? You know, at the time,
this one was a while ago. We don't have that many of them, so I had to pull this one out of the archives. So we didn't have a lot of the serum markers that we currently are using. So her C-reactive protein was up, but we didn't have any of the specific stuff that we're doing. I can ask my I apologize for not knowing all of them that we were currently using for neurology, but they do a lot of this. Obviously, sed rate's the first one, and they break it down. We had a couple of patients here in the hospital, not from a, but if you want me to, I can get that to you. That information. I'll send it up to you guys.
Okay. They aren't that helpful because they're all elevated in pregnancy. All of them are.
There we go.
So they're not that great.
Yeah, you know, we couldn't. Her C-reactive protein was elevated, but again, it was like one of those things. Like we didn't know what it meant. But clearly the angiogram was abnormal, and so we knew. And so we just, like I said, I just gently angioplasty this to kind of break open the to make it be more normal, and then let her have better flow. And presumably, if this is what we think it is, if it's an inflammatory process, this will change and get better, and it will go somewhere else if it continues. I just needed to do the one side because this other stuff on the other side had already gone away. But we know that this side was more involved because of the MR. All right, so dissection. What is a dissection? There are two types of dissections. One is through the intima, which is the one that we end up having to treat because that's the one that actually causes narrowing of the vessel. So you get the thrombus underneath the intima being so, yeah, it just kind of, I tell patients it's like, you know when you're scraping paint off the stuff and you finally get in that sweet spot and you know you're in the plane and it all kind of just goes from there? That's kind of like if you hit the intima, you can kind of get a clot starting underneath and then it just kind of propagates all the way up. And the carotid artery is on the order of about, 4 millimeters in diameter, so it doesn't have a huge diameter. And in women, because we're smaller in general, we can actually be on the 3 to 4 millimeter rather than on the 4 to 5 millimeter, so we actually are at a little more predisposed risk when we start dealing with things pushing that intima across. The other type is an adventitia type of dissection, which usually leads to pseudoaneurysm. Generally, not a big deal because it's a pseudoaneurysm, and it may form clot in there, but you treat that with more like antiplatelet or anticoagulation. So this is a lady that came in. She had had her baby about, I think it was 5 days before. She actually called her husband, saying she wasn't feeling very good. And she said, I'm not feeling very good. And he said, I'll be home soon. He was off for that first week, so it was a weekend. He goes, I just got back to work, but as soon as I can find a break, I'll come home. She called him from the floor saying, I can't get up. I will never forget trying to peel him off of the floor because trying to consent him for what she was going through was very hard. We actually brought her in from the outside hospital, and I had to tell him that, she might die through this, and that was not very fun because she was having a major hemispheric stroke. So when you do this, this is the right ICA, so she was left hemiparetic. She was actually talking. She was an executive in one of the .com businesses, very bright woman. And she was, but she was not moving. And she was talking to us, and she was making it very clear that she couldn't live like this because she was she was neglecting. Her head was buried into one side, and she had a huge facial droop on the right. So she was going full hemisphere down. At a young patient with a full hemisphere down, they do not live, even though it's non-dominant, because they're going to shift and swell into the other side. So those are that first couple days where I worry because of the swelling, because they have no room to swell. So you can see here you have this very telling kind of a flame shape to the internal carotid artery. When I actually get a microcatheter that you can see here and inject it, you can see how irregular this is because this is where the dissection probably started, and and then it takes time for that hematoma to develop. So this is why it can be a couple of weeks week out or 2 weeks out, because it can take time for this hematoma to develop to the point where you have an occlusion. And so she was not filling. So and you can see here, there's no flow. We actually went to the other side, and she's actually filling pretty well across. Not great, but she is filling, she's getting penumbra across. She's getting ACA to MCA, and she has a little MCA here. So we went ahead and I stented all of this and opened it up and gave her better flow. Interestingly, she did have a clot down here, probably because of the low flow state. The good thing is that she actually, she had a dissection on the other side as well, but it was non-flow limiting, so we left it alone and we had to put her on aspirin and Plavix for the stent reconstruction that we did, and that would be the treatment for the other side. When she came back, the interesting thing, when she came back, we did serial ultrasounds of these. This opened up beautifully, and she actually restores her MCA. She had a little bit of, her leg was a little bit worse off than her arm, but she was actually she went back to work and everything like that. The interesting thing is on the other side, it actually, it didn't clot off, but it was more stenotic. And so I felt like, gosh, I guess I should have treated the other side too, but it was not, if you don't have to, you don't do it. So, and you don't like treating both sides because of everything happened. She was a very rough, and speaking of very rough goes in the ICU, for the first 3 days, we had to deal with super malignant swelling of her brain and doing everything we could to keep her alive, and she did come through the other side and did very well. But it was I don't think my family knew me for about 3 or 4 days. I just stayed with her the whole time. So, all right. So Sheehan syndrome, like I said, this is one that, like I said, I have a personal story with, and was glad that I thought about it when I was called to help out on this one. And what this is that, as you know, the pituitary enlarges in pregnancy, secondary to the increase of secretions and releasing factors, and then there's a relative decrease in the arterial supply, and then you add that to the hypercoagulable state postpartum, and this rapidly shrinking the need for the pituitary to be so enlarged, and all of a sudden you get ischemia. What is the presentation? Headache is the #1 because you got this big mass sitting right above your eye, so it's hitting your optic chiasm. So because it's not your.
Attention, please. Code red. May I have your
in about, what is it?
alarm active detector roof?
5 minutes, she's going to call it off.
Have your
I'm sorry. All right. I can't talk over the BB. Okay. So hyponatremia, because we have an alteration in our ACTH, and obviously then the kidneys. That affects the kidneys, and we dump it. There's a low endocrine function, so panhypopit is what you'll be seeing. So breast milk will not be coming in because you don't have any of your hormones to make that happen. The oxytocin and everything just does not happen. Significant blood loss. This is actually more of a risk factor because of the anemia that it creates with all the other dynamics that are occurring. You can see weight loss if it's long term, if they are somehow able to get away from these sorts of things, and then lethargy because of the hyponatremia. And seizure is how my sister's friend came to, she seized and went into a coma. So when it happens, it is unbelievable and rapid. So, and this is what we're talking about. So here's the pituitary gland. You guys all remember this, but I think this is amazing. Okay. It's incredible. That's somebody who did not quite make it through their panhypopit, unfortunately. But that tells you why you might have a headache. That's a pretty good reason for having a headache. And if you remember where this sits, right, here's that pituitary. Here's the carotids on either side, so you can imagine if it gets too big, you're going to actually have even...
I have your attention, please. Code red, alarm active, duct detector roof, AH1. May I have your attention, please? Code red, alarm active.
We're on the first floor. We're good for a few more minutes. So you can see the pituitary gland there. This is our typical CT scan. These are the obviously the coronals that we do, but here's the optic chiasm that runs right on top. So you can imagine right where all of this is located, that can give you a pretty whomping headache if that starts to swell. You know, when we talk about pituitary apoplexy in the general population, which is an ischemic event of you know, an enlargement and ischemic event of the actually vision gets involved. So sometimes those patients present with blindness because of the pressure against the optic nerve. And so the treatment for this is basically supportive. We have to, my sister's friend is on full hormonal replacement, doing quite well, taking care of her 4 kids. And it was her 4th kid that this happened on, which is interesting to me. But it was interesting when she's saying, this has never happened with the other 3. That may be, that when you say what may trigger you to say something's different about this, something like that, where something is very, you know, I had 3 other kids and it never happened like this. And so we tend to you guys could deal with women more than I do in this sense, but my experience has been we tend to underplay what we're experiencing if we can, because we have a lot of other things to do. And it'll come into play when I talk about subarachnoid hemorrhage, which is next, because you know, there was a woman who was just postpartum with an ACOM aneurysm, and she had her babies at home, and they wanted to send her home because they said they thought that the ER doc had done a bloody tap because the CT scan was negative. She was complaining of headache, worst headache of life, for a week, and her doctor said to her, oh, well, you know, you're probably under a lot of stress because of the baby's at home, so why don't you take an aspirin and work out, which she did dutifully for 5 days. Yeah. It's California, though. So what is the incidence of subarachnoid hemorrhage? We'll go through that case. We actually were able to coil her, and she did great. And I get pictures. Her kids are now grown, so it's all good. But like I said, sometimes my instinct there was, I'm like, her kids are at home. How long has she been in the ER? They're like 9 hours, and I'm like, 9 hours? That must be some really bad headache. And they're like, and she did an LP. And he goes, yeah. The neurosurgeon's like, you know, I think this is just because the CT is negative. I think it was just this ER doc. I go, I don't get a good feeling on this one. Send her over and let's do an angiogram. And you know what, one night in the hospital is no big deal. She's already been there for 9 hours. What difference will it make for her? And she had an aneurysm, and actually it was rupturing it was actively extravasating on the table. So, and she was saying, I just have a little headache. So like, she was having a big headache because she was being pretty stoic about it. Anyway, so it's always nice when you get them home, though. So incidence is 1 in 10,000 births. Obviously, preeclampsia and eclampsia because of hypertension. We talk about arterial venous malformations. And known or unknown, and then aneurysm. And I think this gets a lot of attention from everything I was reading. This gets a lot of attention, but I think the actual rupture rate in the population of pregnant women is actually turns out to be about what it would be in the national population. So that's, you know, not anywhere increased, but we always focus on it. The good news is that we usually take care of those patients after they deliver. They work out pretty well. So presentation of an AVM, seizure and headache, bleeding. Most AVMs present with bleeding. It's 3 times more likely, but like I said, it usually occurs antepartum, in the antepartum period, which is kind of interesting, the majority of these. So it's one of the ways you can tell that this is not usually an aneurysm. So I'll just run through this is a hemorrhage from an AVM. Here are those little vessels. Here it is on angiogram. You can see what an AVM looks like and why it would be predisposed to rupturing. Like I said, usually when all of the hemodynamic changes are occurring in that first trimester. Presentation of an aneurysm. Here's a little aneurysm bursting. The population is about 1%, and it doesn't really change. It's about that in your population as well. People have always thought that birth trauma increases the risk of rupture. What you're looking for is this sort of stuff. Meningeal signs do not usually happen with migraines. I've had lots of migraineurs that have had ruptured aneurysms, and not in the pregnant women, but in the general population. They tell you, absolutely can tell the difference between the two. So worst headache of life, rapid, acute onset. They can get neck stiffness. You know, they don't want to Patrick. I had one lady who swore it was her knee. She's like, no, why are you worried about my head? This is after she comes through the rupture and the coiling and everything. My knee really hurts. And I'm like, We kept trying to tell her. She would not listen to us. Well, it got better after 2 weeks because the blood went away, so it was all good. And her knee felt better, which was all. But that's part of that meningeal or meningismus that we see. So here is a CT scan. You can actually see the temporal tips are a little bit elevated because they're probably a little hydrocephalus here. Here's that wonderful look of a subarachnoid hemorrhage. You can see all the sulci are nice and bright because of the bleed, because it's really bright. This is the aneurysm I was telling you about. I'm showing you two different types of aneurysm, but this was that woman that I was just describing to you with her ACOM aneurysm right there. We coiled that and took care of it, and she actually got to go home 7 days later, which was really nice. Here's a basilar tip aneurysm, so here's the vertebral artery coming to the basilar, and there's an aneurysm. I like these because we get to coil them and treat them and get it done. I like that. So I just wanted to show you a brief difference between an intracranial hemorrhage and the subarachnoid hemorrhage. I think you can all tell that this is in a different spot. This is an old lady. You can tell this is what I'm used to dealing with. Look at these. Look at this CT. That is much more like when I said the other one looked good. There's a reason. It looked really good. This is my old lady, but I wanted to give you an example of what an intracranial hemorrhage looks like. And like I said, this is the one we worry about. And usually this is because something's, this is not because of an aneurysm or an AVM. This is something deep inside the brain that is ruptured out, usually from hypertension. And we all know the risk factors for you guys are the risk factors for us. You have those diabetics, hypertensive patients, you know they're going to be your test patients, these are the high-risk OB patients. They also are the high risk for bad things happening because they can get the peripheral artery small vessel disease that they get, and then they can rupture that during, if they get too high in their blood pressure. So briefly, last things, eclampsia, you guys could tell me more than I could tell you probably. Like I said, I just always remember, get the baby out. We're going to be all good if we get the baby out. Press, like I said, it's a kind of a misnomer in terms of things because it doesn't always meet all of that, but that's what we do see this actually more frequently than you guys think. When someone's confused, it's just not like a big presentation of like a neurologic deficit where you see one arm going out or one leg going out, but they're just not right, and they're maybe a little weak, and then something else is happening, and you'll see why when you see the pictures. It's because of the autoregulation and the passive dilatation of the cerebral blood vessels have changed, and so there's extravasation of fluid and proteins into the interstitial space. This is, here's your eclampsia. You guys know that. See? That's what I always take out of this one. And then this one, headache and seizure. I've seen seizure quite frequently. I've seen some focal neuro, and like I said, this is the main thing. It shifts around. So if it's like, and then what most people do, they see a woman and they're like, oh, well, she's just making it up. She must be crazy doing this. And it's like, well, no, I actually think it's real. And then what happens is you see this. You get this, you get this, you get this, you get this, you get this. You get little spots and dots all over the brain, usually in that posterior circulation, so cerebellum, occipital lobe, but you can get things outside of it. And what happens is that that's why they can get those shifting symptoms. The thing to do here is to be supportive. Antihypertensives are the most important. As that fluid reabsorbs, the function comes back, and they actually do fairly well if you can catch it and keep it from moving forward, because it progresses. If you don't,
high blood pressure?
Generally do. And eclampsia history is common to see. So, oh, well, they were clamped, but they're better now. And it's like, okay, so but they were. And when did they start having symptoms? Well, they had the symptoms back then too. So what we hear a lot is that they didn't really ascribe the symptoms to a neurologic deficit. And then when you start peeling back the layers of the onion after you see something bad, after you get the MR, then you start to realize, like, well, actually, even right after they gave birth, they were talking about how they had this headache and they weren't quite right. And that, so it's not, but like I said, it's kind of not in your face. It's not in your face type of stuff. It's more the subtlety. And then until they get the one that goes in your face, then that's when you get the scan and you realize they have all these little things everywhere, and it was probably started earlier than you thought. Yeah.
Will they have residual effects of that on scans later?
Well, that's why it says it's reversible, and that's why I said it's not always reversible. Yeah. We like to say it's reversible. The majority do, about 90% reverse.
Because I had a patient the other day who had some unusual findings on scan with history of headaches, and then nothing ever amounted to anything in the workup. Mm-hmm. So you're just wondering if she has something that went undiagnosed.
Yeah, well, it's like I said, it's supposed to be reversible. Not everyone reverses, so you can see some lasting sequelae of it, some of that white matter. Some of these may stay, get smaller but stay. So you may see some little dots.
Worth it to work up in the future?
The problem is that there's nothing, in terms of how we deal with this, it's only supportive care. We just keep that blood. The main thing is the blood pressure. You may use steroids at times, and we don't typically, but you may. It's really about the blood pressure and making sure, because these patients tend to be it's like when you have your gestational diabetic patient, you kind of may have an instinct that patient may go on to diabetes later. It's that kind of same thing. It's that they may be hypertensive that we just didn't realize, or they didn't realize and they haven't been treated before. I think there's a lot more hypertension than we realize in our population, and it's just because people aren't getting their blood pressure tested. I was in the gym, and, this woman came in, and she, probably 30s. She's talking to her friend, and she's like, yeah, they put me on 3 antibiotics. I'm just not going to get on. I'm like, she's in the gym. I should be happy, right? I'm like, I shouldn't be hearing this conversation. I should just go in the shower. I'm like, take your meds. I'm like, no, we don't get paid off by the drug companies to prescribe you antihypertensives. I'm like,
Call red, alarm active, second floor, dust detector, 8H1.
So, if you guys, the one thing I would say is that if you feel that you have a patient that you want evaluated, give us a call. If we've gone up to labor and delivery a few times, we don't have a problem. It's better to be safe than sorry many times. I'd rather go up and do 3, consults that amount to nothing than miss the one because this is the saddest part for me. These are young, very vibrant people that just had kids or are having kids, and the last thing we want to do is not address something that can be addressed. You have the resources. We have the ability to do stuff. So please, if you're feeling like there's somebody that needs us to look at just to double check, if you have an instinct, we're here. So please give us a call. We're more than happy to come up and see somebody. But we'll have you also badge us in because they don't let us do anything up under the
In this situation, we use usually hydralazine and labetalol indiscriminately. Is one preferable in this context to the other?
I tend to be a nicardipine user because it's a calcium channel blocker. It's a little softer and easier. What I find is that, I like drips. And if you have somebody that's in this situation, they're in the unit, they go to the unit, and they get placed on a drip. Can you use a labetalol drip? Hydralazine, we generally don't use the hydralazine drip. We use but I've seen a labetalol drip. I generally like nicardipine because it vasodilates in addition to the fact that it lowers the blood pressure, and usually is a pretty softer drug, so we don't have to use as much, which is very nice. But you need that drip until you can get them really under good control, and then once you do that, then you add the orals. What I find about giving pushes, although in the moment it's absolutely a reasonable thing to do, but if you keep doing that, what happens is a spike factor. So when you're talking about aneurysm, for example, you're saying, oh, I just want blood pressure, and you give boluses. It's those spikes that occur that are the real risk for the patient with hypertension and the aneurysm, because it's not like, oh, well, they're at 150. It's when they rebound off of 120, and now they rebound up to 220, and then they come back down on you. And we're not monitoring them that closely. You don't see that. You don't have an art line in watching it. But if you have someone with press that's really symptomatic, that's what they're going to do. They're going to go to the unit. They're going to get an art line. We're going to be giving them a drip to keep their blood pressure nice and controlled, and let them try to recover.
Just say a few words about C-section with people with.
Oh, yeah.
Yeah, the going thing is because of the stresses, right? So it's interesting when you read the articles. I did pull that article if you guys want it from the NIH. It basically talks about how we do these things preventatively, but yet there are changes in stressors that occur that increase the hypercoagulable state in a patient. So are you really helping or are you not helping? And I think it became a wash. And when they looked at aneurysm specifically, what they said was that the risk that we really get hung up on the fact that there's a weakness in the vessel wall in someone's brain, and that, we're like maybe found because someone has a headache and then they find out they're pregnant. And then all of a sudden it's like, well, we just want the patient to deliver and then we'll take care of the aneurysm because no one wants to take care of the aneurysm.
May I have your attention, please? Code red clear.
May I have your attention, please?
I think it was
Code red, clear.
So then the question is, because I think it's just because of the risks, we say, oh, we're going to do a dissection on, but then that can actually increase your risk for other things happening that are down, and what are you doing? You're doing it because of the potential risk, and potential risk actually doesn't seem to pan out for aneurysms themselves. Now, AVMs, you could argue, well, it does, but the AVM typically doesn't bleed in the third trimester, it usually bleeds in the first trimester, so it's kind of an interesting thing. And the risk once you've bled is about...
May I have your attention, please?
You compete.
The hospital fire alarm system is disabled at this time. For emergencies, please dial 711. May I have your attention, please? Please, the hospital fire alarm system is disabled at this time. For emergencies, please dial 711.
Is that going to change, from a medical legal risk factor, you're going to do the C-section? Just be aware that it does,
we inherit the C-section that's already been declared by the neurologist.
Right.
The neurologist told me I have to have a C-section.
That's it, case closed.
Right.
It's like,
Or something happens,
that's not true,
you don't
but
have
you can't do
exactly.
some other one. And like I said, there's roped into it from the first
there's stressors with all these things. I mean, so I think the interesting thing is that when you really look into the literature, that it turns out that it really is.
So an AVM with intracranial pressure increase, is that an issue?
This is what I'm saying. Usually it's more it's not the pressure for an AVM. It's not pressing down. What it is it's the fluid dynamics in the woman. And so generally speaking, when you look at the statistics of when AVM ruptures, it's in its first trimester. So you don't really first to second trimester. You don't usually when everything's going haywire. I say haywire because I couldn't exercise. I was getting so upset because I was like I don't even know big. What's wrong? And I'm like you're just haywire. Your body's not haywire. So it is interesting to look at the AVM statistics of rupture, and the AVM statistic of rupture is that they bleed in that first trimester. Now, I will say, if they have bled in that first trimester, well, then I think you're truly obviated because now you're dealing with a much more increased risk because you have a weak bed within less than a year.
What about the shifts postpartum? Because we have a lot of fluid shifts postpartum.
But it's the other way.
inductions are huge.
Yeah.
I know.
That's what you see in the
much
section.
greater than the shifts with pushing.
We have a patient who not only had been given a coronary conversion pregnant, obviously she had an AVM that was and her neurologist said, absolutely no labor, C-section. Was there anything preventative or anything we should think of doing postpartum to make sure she has, make sure she gets anticoagulated? We do the venodynes are ready, make sure she's well hydrated.
I just make sure she's well hydrated because I think that's the main. When you talk about the real risk, it is all of those fluid dynamics, but it's the dehydration that can occur, and and then breastfeeding on top of that is more dehydrated. So I think it's the dehydration probably more than anything else. But it's tough because these are such rare events. I mean, it's so rare to get that constellation of things is so rare to have, but then it all happens in one patient.
We got them, no?
Yeah, we got them. No, you do. And then the question is, what is, the problem is is that there's so much out there reactionary. It's hard to get around it as to what you're supposed to do. But I think it's always something to keep in mind that the C-section isn't benign. That it can add to other, like you're saying, other dynamic shifts that can occur just because of the operation, third spacing and fluids and electrolytes and all that sort of stuff.
So if you see them first, we won't crack them, and then most of the time they see somebody else who crack them.
Thank you very much. That was really very helpful. Thank you so much.